old, you had high blood pressure.
120 over 80 now.
Two heart associations, the American College of, the American Heart Association and the circulation group, came up recently and said, nope, it's 130 over 80. That's high blood pressure now. Minimal high blood pressure, but high blood pressure. And they changed the definition of normal blood pressure to less than 130 over less than 70. This is a big controversial item now. Everybody agrees, however, that if you are in the 130 over 80 range or higher, and you have other major risk factors, namely, particularly, diabetes, known heart disease, known strokes, or kidney problems, that your pressure should be lowered. No more kidding around with blood pressures of 140 over 90. We try to treat all of them now. If your blood pressure is 130 over 80 and you're 25 years old, there's a good chance that when you're 40, you're going to have real high blood pressure, and that should be followed. I have a lot of people who have blood pressure cuffs at home now. They're not terribly expensive. They're worth your while. They will save you trips to the doctor, and they will give you a better idea of what your real blood pressure is. And I strongly recommend anybody who's ever been told about high blood pressure, or if you have someone in the family with it, get one of these cuffs. The best one is an Omron, O-M-R-O-N, sounds like moron, but any moron can use them. And I strongly recommend that when you first get them, take your blood pressure twice a day, usually before breakfast and before dinner, and record it on a piece of paper. And if you have any questions, ask your local physician. Very important. Now, how do you take blood pressures? Every one of you has gone to the doctor recently, and every one of you has had his blood or her blood pressure taken sitting on that examining table at the end, and some nurse comes along, walks into the room, grabs the cuff off the wall, sticks it around your arm, and says, your blood pressure is X over Y. That's not the way you're supposed to take blood pressure. This is going to become a big problem, because the way to take your blood pressure really is to sit down at a table, put your arm on the table, and relax your arm for 5 minutes, and then have your local friendly medical assistant come in and take your blood pressure that way. That takes a lot of examining room time. It takes a lot of nurses, medical assistants' time, and theoretically is more accurate. I don't know the answer to this yet. We are trying very hard in our office to take your blood pressure in a chair, and we have to move the furniture around to make it more practical, because that's going to have to be done too. And but if your pressure is high, it's not going to be too low if you take it the old-fashioned way. If your pressure is high, make sure it gets taken again at that particular visit after sitting down for 5 minutes, relaxing, and getting it done in a relaxed kind of way. But the best way to do it is if you can do it at home. If you get a machine at home, by the way, get it checked out by another machine, whether it's your neighbors or your doctors and so on, because there are some that just aren't right. There are 4 different major kinds of blood pressure medications. They are called calcium channel blockers. That includes amlodipine or Norvasc, which is the most commonly used one. Diuretics, the most commonly used one is hydrochlorothiazide or HCTZ. ACE inhibitors, which include anything that ends with pril, P-R-I-L, quinapril, acupril, lisinopril, and so on. And angiotensin release blockers, which all end in tan, like losartan, valsartan, and so on. And I'm going to go through that in a moment. Different groups of people who treat hypertension choose different kinds of medications to start with. A lot depends on your age, your size, your weight, and various other things, and so on. But a recent paper said that given a dose of antihypertensive medication, sometimes you're better off taking a second one if it's not working, rather than increasing the dose of the first one. All of these things have side effects. There really aren't terribly common side effects. Stick with them if the side effects are not bad. It's more important to get your blood pressure down than some other things. Now, what's the most important treatment for high blood pressure? Anybody? Most important treatment for high blood pressure?
Lose weight. Lose weight.
Diet. Correct. Lose weight.
And marriage
No.
counsel.
And no stress.
And marriage counsel sometimes.
Marriage
Seriously, thanks, Alan. Seriously, your weight determines your blood pressure to a great extent. There is something called the DASH diet, which is dietary assistance to slow hypertension. That's the acronym. There's another diet. There are several diets, but called the Mediterranean diet, but they're all basically based on the same thing. And what's the most important thing about both of these diets? What is not in the diets that people consume too much of?
Salt. Sugar.
Salt. Salt is worse for your blood pressure than sugar. I mean, if you had to choose one, neither one of them is any good. But salt is not good for you. Diuretics, which are one of the medications to treat you, are really what they call water pills, but they're water pills because they get the salt out of your body and the water follows them. Strongly recommend these diets. Eat fish at least twice a week. We eat fish 4 or 5 times a week. Fruits, nuts, vegetables, the stuff you see outside. No salt. There's no salt in the nuts. Avoid fatty meats. Avoid whole milk products. Avoid starches and sugars, which are almost as bad as salt. We are going to have another session, I think it's in January, on diet with a dietitian and on bariatric surgery. We had one the first year. Bariatric surgery is real. It isn't as good as getting on a diet and staying on it. It's really important. Little pearls, sweet potatoes are healthy. White potatoes are not. Soda is poison. Fruit juice is really not much better. It has some vitamins in it, but when you make a fruit juice out of oranges, you get rid of all the fiber, unless you keep the pulp in. And ice cream has a lot of fat, and cake and cookies and pasta are basically turned into sugar in your blood. You can have some, but not too much. Teach your kids how to make fish. Teach your kids how to make other things like that.
Bless you, bless you.
Gesundheit.
A huge study showed that reducing your blood pressure, if it's elevated over 140 to 150, getting it down to about 140 does a lot more good than getting it much below. And sometimes you don't really want to push it too low because not only can you get more side effects, but particularly what may happen is that it's not going to do you very much good to a certain point. In high-risk patients, people with diabetes, high cholesterol, vascular disease, you should go below 140. I'm going to talk about diabetes and then I'm going to talk about groups of medications. I'm only going to talk about diabetes type 2 because 1 is not as common. And frankly, we all send our diabetics type 1 to endocrinologists.
Can't do too much about type 1, really. Can't do too much about type 1, really.
You can do it. No, that's wrong.
Type 2
because
is controllable.
Type 1, you can do a lot about
Diet,
type 1 because there are newer insulins and there are ways to check your sugar. And most important, and one thing I do want to say, there are new monitors that will read your sugar right off the meter as it is attached to you, rather than going through the rigmarole of sticking your finger. And those are out there, and if your insurance company lets you get one, you should get one.
Insulin pumps too, they monitor you, and adjust the dose as you need it during the day. It's automatic.
Should people be screened for diabetes? Well, they've changed the numbers again. When I was in school, the way we determined whether somebody had diabetes was we put them through a glucose tolerance test. Glucose tolerance tests are only useful now if we think you have a low blood sugar caused by excess insulin, which is fortunately very rare. If you have a high blood sugar on a fasting specimen, or if you have a sugar of over 140 on a non-fasting specimen, you should have a test called an A1C test. What is that? Hemoglobin A1C is sugar in your blood, glucose in your blood, that's been attached to a sugar, your hemoglobin attached to a sugar. And there's a percentage of that in your body. The percentage that is considered normal is up to about 5.6%. 5.6 or 5.7 to 6.5 roughly is what's called pre-diabetes, which means that there's a good chance that you will get it and so on, and that you should watch your diet at this point, and you can avoid getting it if you're overweight, and if you get down to normal weight. That's a fact. If you go above that number, you are called a diabetic. Now, A1C tests, within the last 2 years, the rules about them have changed, and you should be aware of this. There was a time when if you went to your doctor, the aim was to get your A1C down to less than 7%, that magic number of 7. And all of a sudden, people began to realize, and there have been a few papers about this within the last year, why are you taking an 85-year-old lady who has mild diabetes and weighs 130 pounds and takes her medication faithfully and doesn't have high blood pressure, and subjecting her to the dangers of getting too low a blood sugar? So we've changed the rules to a great extent. Yes, most young people with type 2 diabetes should be less than 7. But if you are an older person, the way they say it, and I hate to say this, if you are expected to live less than 10 years, and especially less than 5 years, they let you go to 8, and even 9 now. Medicare used to pay you. They used to pick doctors on the percentage of people who had A1Cs of less than 7. This created a lot of problems. It got some people down too low, and more significantly, a lot of doctors would get patients to come in right after they ate. Their blood sugars would be a little high. They knew their A1Cs would be normal. They took their A1Cs, they were normal. They got better report cards, even though they were doing the wrong thing. I never did that, but I know it was done. But the A1C is still an important test. What medications do we use? There are many, many, many new medications for the treatment of type 2 diabetes. And the basic medication for everybody, unless you have a reason not to take it, is something called metformin, which has been around for a long time, also called glucophage. And there's no question that everybody with type 2 should be taking metformin unless there is a reason not to. And there aren't too many reasons not to. Some people don't tolerate it. Some people get diarrhea from it. But they should be doing that. Now, new groups of treatments. Something called sulfonylureas have been around for a long time. These medications all end, the generic names, all end in IDE. Lameripride or Amaryl, chlorpropamide, glipizide, glyburide, all of them are sulfonylureas. They were the original metformin, the original anti-diabetic medications. They are being abandoned now for two reasons. One is they cause low blood sugar more often than others, and two, they cause more side effects, and the long-term studies are not that great relative to the newer ones. There's another group called thiazolidinones. They all end in azone, like pioglitazone, rosiglitazone, which are actose and avandia. Those aren't being used too often, again, these days, because they too can cause a lower blood sugar. there are two major new groups of anti-type 2 medications out there. One of them is called the dipeptyl peptidase 4 inhibitors, or DPP4 inhibitors. And they all end in gliptin, sitagliptin, saxagliptin, linagliptin, and allogliptin, which are also called Januvia, Onglyza, Trajenta, and Nacina. Pharmaceutical companies pay a fortune for people to make up names, generic names, so people don't go to their doctors and ask for saxagliptin, which they can't pronounce, or sitagliptin, or anything like that. My medical students come to the office, and they all come out, they are taught at school, you dare not use any brand names. You must learn in school to use the generic names. And they come in and they ask patients, are you taking saxagliptin? Are you taking canaglozin? People don't know what they are. So I use brand names and because people just won't remember generic names. But I have a story about that, and I have to tell the story because it's actually been published in a blog. I have one elderly woman that was over 90 who went to an urgent care center for a cold and got what's called a Z-Pak, an antibiotic, and so on. And she came back to see me a few days later just for a follow-up with her daughter, who was insisting all the time that this lady can't remember anything. Mama can't remember anything, and so on. And I said to the elderly lady, I said, how are you doing with the Z-Pak? And she looked at me like, what are you, Craig? What's that? And the daughter said, you know, the antibiotic. And the mother said, oh, you mean the azithromycin? The drug's been out there for 20 plus years. That's the first time I ever heard anybody, a patient, say that word. But she remembered it. I told the daughter she did not have dementia. And I actually sent it to a man who runs from Harvard, who runs a blog every week in the online, and he published it, and he said to me, no, you made my day. But because he's all for generic names, no way. Sodium glucose cotransport inhibitors, Invokana, Farxiga, Jardiance, also called canagliflozin, dapagliflozin, and empagliflozin. Try to remember those. These are the newest things out there. They're very effective. What they do is they keep your kidneys from reabsorbing the sugar that's in your body. And so that you end up, one, losing weight because you're getting all this glucose out in your urine, and two, you are able to eat more and so on. The problem with them is that they sometimes cause urinary tract infections because of the way they work, but they are certainly something to consider. The other problem with them is that they're all branded. None of them is generic at this point. Your insurance company is not going to let you have it unless you get a prior approval, which means you have to genuflect and do a lot of other things for them. It's a big problem. Other new medications, a very important group of medications, which are out there and which are being used frequently, are called DOACs, or direct oral anticoagulants, or NOACs, new oral anticoagulants, DOACs, or NOACs, not NOACs, no, NOACs. These are also called Brilinta, which is ticagrelor, Plavix, which is called Pritigrel, Effient, which is Prasugrel, Pradaxa, which is dabigatran, this group, Eliquis, which is Apixaban, Xarelto, which is Rivaroxaban, and Savasa, which is Indoxaban. That group, they work different ways. But the bottom line is they are replacing warfarin or Coumadin in the armamentarium of people who need blood thinners, whether they've had stents put in, or whether or not they've had phlebitis, or whether or not they have atrial fibrillation. They're good, they work, they don't cause any more incidental bleeding than warfarin Coumadin does, and you don't have to go to the doctor every month to get a blood test, or more frequently, to find out whether you're taking the right amount of medication. Somebody asked me to talk about the naming of drugs and the brand names and so on. If you notice, all generic drugs in groups have the same ending to their names. The trade name may be totally different, but the generic names are all very similar. That's the way to identify. If your doctor says that your losartan is not working and when he gives you valsartan, he's really switching one for another. And basically, they are all interchangeable. It's rare for one person to be allergic to one of them and not to others. It can happen. Okay. Continue on. Lipids, again, we talked about diabetes, we talked about high blood pressure. Lipids, cholesterol, what's the ideal lipid number? When I started out in practice, when normal numbers were considered something related to the standard mean, a cholesterol of 300 was considered normal. That's a fact. That didn't last for very long. We really want to follow your LDL, the low density, bad cholesterol, and the HDL, the high density, good cholesterol, and the triglycerides, which are the other major fat in your blood. Your LDL should be less than 100. We accept up to 130 for people who are young, healthy, and otherwise fine, but warn them that it's going to get higher. If you are a diabetic, if you have heart trouble, we try to get it to be less than 70.
Less than 70?
Less than 70. That is correct. I don't force that because it creates a lot of side effects, but that's a fact. That the AHA recommends that, other people don't. And every organization has different numbers. The American College of Physicians, which is the internist organization, has higher numbers than the American Heart Association does as normals. It's a fact. It's crazy. HDL, that's your good cholesterol. The higher it is, the better off you are. They've been looking for a way to make it higher. There really isn't any way that works very well to do that. Eating this, taking fish oil, all that kind of stuff doesn't really work in the long run. Fish oil, we'll get to in a moment. But if your HDL is over 80, that's great. Generally speaking, that protects you. If it's less than 40, that is not good. But you can't do anything much to change to a higher number. They got a drug. Pfizer spent a fortune of money getting a drug a few years ago. They gave it to prisoners, and they killed a lot of prisoners. They thought maybe Trump would like that. But they killed a lot of prisoners because the stuff was more toxic than helpful in getting your HDL up. Obviously, they never marketed it. At any rate, the basic medications for them are statins. That's, atorvastatin, Lipitor, rosuvastatin, which is Crestor, simvastatin, which is Zocor, and a few other statins. They all end in statin, and that at least is a name that you can pronounce to some extent. These get your numbers down, and the best ones to take if you haven't done well with another one are either Lipitor or atorvastatin or Crestor, which is rosuvastatin, because they will lower your triglycerides to some extent, and at the same time, they can be taken any time of the day and once a day. The others are a little more complicated. There is something out there called red rice yeast, which a lot of people try to market. It will lower your cholesterol to some extent. Why? It's over the counter. Why does it work? Because it has a statin in it, in the natural product of yeast. But the statin amount you get may vary from 0 to a lot. And every batch is going to be different that you buy. And they're all imported from China, and the FDA has outlawed any altered red rice yeast, where they deliberately try to get the number down, but your local Chinese dispenser is not going to follow that. So if you take red rice yeast, it may work, but it won't work forever, and you never know what you're getting. And it has a lot of calories. So I would avoid that. There's not much else to say about that, except two things. There's a medication out there called Zetia, Z-E-T-I-A, also called ezetimibe, that's the generic name. That's been around a long time, and is pretty much available now. In people who cannot take statins because they affect your liver tests, or because you get side effects of other kinds, they work in some people and do not work in others. And the reason is that the way it works is it does something in your intestine that keeps you from absorbing cholesterol if you have a certain enzyme. If you have that enzyme, it'll work. If you don't have that enzyme, it won't work. But it's worth trying if you can't take a statin. There's also a powder called Questran, which is an awful thing to take and constipate you. That will always lower your cholesterol safely, but nobody can tolerate it because it's constipating. Okay. Pain. A recent study shows that ibuprofen and acetaminophen together, that's Advil, Advil, and Tylenol together is just as good a painkiller as an opioid with acetaminophen. They actually gave people identical looking capsules, and that way you don't have to get an opioid. How many people in this room, raise your hands, you don't have to, but have gotten an opioid from their dentist, orthopedist, or somebody else this year? Most is right. When I see somebody coming into my office and I see the list of medications, and they've been giving an opioid and an antibiotic, I say, when did you go to the dentist? If they're given an opioid and an Advil or something like that, ibuprofen, when did you go to your orthopedist? Orthopedists and dentists notoriously, and they're stopping now a little bit, give people anywhere from 6 to 25 opioids when they come in to take care of their pain. If you've got a dental implant, you may get one. If you've had a little simple bursitis, you may get one. My chief of service was looking in his medicine cabinet one day, and he saw a prescription for his daughter, 21-year-old daughter, for Percocet, for 30 Percocets. He counted them, there were 30 left in there, and he asked her what happened. She said, when I had my arthroscopy, the orthopedist, and he's a very good orthopedist, gave me those and said, if you have pain, take one of them. There are lots of opioids being wasted that way, fortunately wasted. There are a lot of opioids being sold that way, and that is part of the opioid crisis. You read about the problem is because of the junkies, the problem is because of the dealers, the problem is because of the pharmaceutical companies. A lot of the problems are because of your doctor. And if he offers you an opioid for whatever reason, or she offers you one, unless you've got really bad pain, refuse it. Please refuse it.
Could you give us the name of some opioids so we know what they are?
Opioids,
Some names of opioids besides the Percocet?
morphine, Percocet, oxycodone, codeine,
Tylenol 3.
Tylenol 3. There are a lot of things with a 3 at the end.
Just read the newspaper.
They're all opioids. Okay, back pain. How do you treat back pain? First thing your doctor should do is examine you. You can't do this one remotely. Most back pain, and this has been well established with a couple of studies, at the end of 6 months, if you get physical therapy without getting any imaging, without getting any other tests, most back pain will be better at 6 months with physical therapy than with anything else you can name. Yeah, sure, the opioids will help you right away, an injection will help you right away. If you don't get physical therapy, chances are in 6 months you are going to end up with the same pain. What am I getting for my backache now? Physical therapy. I went this morning faithfully. And let me tell you, it's a workout and it hurts when you're getting it, but in the long run, it works. It's also been shown recently that if you have meniscus pain, this is a study that was recently done. In other words, if you mess up your knee mildly, what orthopedists have been doing recently is saying, oh, you need an arthroscopy. So they took a whole bunch of people in Sweden, they gave them half of them arthroscopy, they gave half of them physical therapy. Guess what happened at the end of 6 months? Who had less pain?
Physical
The
therapy.
physical therapy people. There's been something in the papers, and the rest of this is going to be brief runs to different things. Something in the papers recently about contaminated medications. A medication called valsartan, which is a blood pressure medication, which is generic. Some company in China was hopefully inadvertently putting some cancer-promoting drug mixed in with it. It was just a technical thing. It wasn't dangerous or anything like that. The FDA was on top of it right away, and recalls were made. Some of you who were on valsartan may have gotten one of those and you should have gotten a recall, but most valsartans are fine. Psychiatry. I've asked a few psychiatrists, what's new and good in psychiatry this past year? And unfortunately, there wasn't very much good in psychiatry this past year. One thing they told me to keep an eye on is something called ketamine, which is a medication that is still being given intravenously to help induce anesthesia, and they have found out that it works for pain very nicely. But, of course, they have not developed an oral preparation of it. But be on the lookout for that in the future. Something very important, early identification of postpartum depression finally came out with a paper this year saying it should be identified and treated earlier than it is. Unfortunately, that has not been the truth in the past. PSAs. You all heard about PSAs. We actually had somebody talk about them recently. I know a couple of urologists. In order to see them, whether you're 50 or whether you're 80, you've got to get a PSA. It's like buying a ticket. Speaking of tickets, we still have the World Series ticket raffle going on. We could check out the Yankee score, but if you're in it, buy a ticket. The PSAs, everybody agrees, who has any sense, they really should not be given routinely to anybody other than between the ages of 55 and 70, and only after a magic thing goes on that's called shared decision making. What is shared decision making? That is basically the medical term for shalom bayis.
What is a PSA? I'm sorry.
Prostate you should decide if you're a man between 55 and 70 whether you want a PSA or not. If you have an elevated PSA, very often it's going to lead to a lot of testing, some of which might get you into big time trouble. And it's been shown, it really has been shown, that most men with prostate cancer identified between 55 and 70 have the indolent kind, that's over 90%, that never kills you and just goes along, and they don't need, they're better off without getting the radiation therapy and other things. The old-fashioned radiation therapy. We're going to have a cancer session in December, and one of the speakers is going to be somebody who's going to be the Dr. Gill of Queens, if you will. But you've heard the ads for Dr. Gill on CBS Radio, among other places. And I suggest you come to that one because we're going to learn a little bit about future cancer targeting and so on. And that's really exciting, but it's not here yet. There's one other thing about psychiatry. This was actually on the news, not in the medical stuff yesterday. There is something called, I'll find it. You can get a kit now in some places which are called, something like psychogenetic psychiatry. It's a kit where you can buy the kit and will tell you whether or not you're subject to getting bipolar disease or various other psychiatric illnesses and what might be the best medication for that. Strongly recommend that you do not get these things yet because they can drive you crazy. So anyway, PSAs, no. If you have a kidney stone, what do? There's a new treatment for kidney stones. It's an old-fashioned treatment, something that used to relax your prostate called Flomax. Flomax will relax your ureters too and help you pass your kidney stone. Most doctors are aware of this. What happens if you go to the doctor and he says you've got some microscopic blood in your urine, or even thick blood in your urine? Used to be that your doctor always insisted that you get a sonogram to make sure there weren't any stones or big things in your kidney. And he insisted that you get a cystoscopy, where they put a tube into your bladder to look at it directly to find early bladder cancer. And he also, if those were negative, insisted that you get a CAT scan, which involves contrast and a lot of radiation. They're backing off the CAT scans these days, sorry again, Mark. But you may not need that CAT scan unless it's persistent and becomes more.
Is the Fomax being used for women as well as men?
Well, sure. Yeah, if you have a kidney stone, it relaxes the upper part of your system, and you don't have prostate. It's not going to affect that in any kind of way. Although one time, one of my girls made a mistake and identified a woman, identified a man as a woman, and the lab said, "I'm sorry, her PSA is elevated." Colonoscopy and colorectal screening. There is no question. If there's anybody in this room who has not had a colonoscopy or colorectal screening, unless you're less than 50, so there are some people less than 50, you must get colorectal screening. The incidence of death from colorectal cancer has gone this way because people are getting either colonoscopies, virtual colonoscopies, which are not quite as good, and even stool tests for blood, and there's a newer one that's better than the old one. But funny, if you offer people one or the other, a study just showed that if those people who chose not getting a colonoscopy but doing the chemical test did not return the chemical tests more frequently than those people who chose colonoscopy refused to get a colonoscopy. If you get the
How often
test,
should you have a colonoscopy?
colonoscopy is normal every 10 years and not over the age of 75 unless you've had a history.
Once every 5 years, no?
Pardon me?
Once every 5 years.
No, 10 years.
Starting at 50, not over 75. African Americans over 45. That's the new rule.
That stool test is okay to take?
Pardon me?
That stool test.
The stool test is okay to take and do it. It's not as good as a colonoscopy, but it'll identify most cases of early colorectal cancer. A couple of interesting developments.
Excuse
Tony,
me, 75, no more on the 10-year?
if you have been negative up to 75, period. That's it.
Even
That's
if
the, I
you,
mean, that's the rules. I didn't make them up.
even if you have a family history.
If you have a history of polyps or cancer, or a strong family history, you can get one every 10 years after that. I don't think too many people are going to volunteer after 85.
Up till 85?
75, basically 85, if you've had a history. Couple of very interesting kind of things. If you've had diarrhea and your doctor has asked you to get checked out for salmonella or shigella or any of the infectious causes of diarrhea, there is a new test, a PCR test, which checks for all of these things. It's a little specimen that you have to give, and again, some people won't do it, but that will identify a lot of stuff, and it's an overnight test, and you get it back real fast. Something I just saw today. Anybody here have a puppy? We're planning to get one. So anyway, they discovered that a major chain of pet stores, whether it was, I don't know what it was, whether it was Petland or whatever, particularly in Ohio, their puppies were carrying a bacteria called Campylobacter, which causes diarrhea. And a whole bunch of people who got puppies from this organization got diarrhea and were found to have Campylobacter. They checked the doggies, the little puppies out, and the puppies had it. They were giving them something that was causing it, and the breeders were spreading it. So if you get a puppy and they get diarrhea, have your doctor check you and your puppy for Campylobacter. Interesting. Pepto-Bismol, I have to mention this because it comes up too often. Many people who get loose bowel movements take Pepto-Bismol because they've heard of it. Pepto-Bismol is bad stuff. Pepto-Bismol, if you look at the label, has aspirin in it, and it has something called bismuth in it. Aspirin can make you bleed if you don't need it. It doesn't do you any good. Bismuth is something that doesn't really help your diarrhea, but turns your stools black or dark gray and scares you. Don't take Pepto-Bismol.
Ammonium is good?
Ammonium's okay, limited.
What about my Lanza?
Well, Malanta is good for some heartburn. There's something, getting to heartburn. Some people are saying that we're using too many PPIs, Prilosec, omeprazole, stuff like that. And there are some papers out there that say they may cause memory loss, they may cause hypertension. Nobody's really proved that. These are speculative papers. If you really need it and you get heartburn without taking them, not a bad idea to take them. Okay. Aspirin itself. Aspirin has been used for years for people with vascular disease and even without vascular disease. There was a Harvard study called the Nurses Study that showed there were fewer strokes in nurses, women, who took aspirin than in those who didn't take it over the years. Unfortunately, or fortunately, two papers came out this year, one saying that taking aspirin rather than anything else is not a good idea for vascular disease. You're better off taking a NOAC or a DOAC because aspirin causes more bleeding, and which is harder to reverse. And most particularly, if you do not have vascular disease, heart disease, significant hypertension, taking aspirin after the age of 70, which a lot of you do, is not helpful. It doesn't do you any long-range good and may make you bleed. Aspirin is on the way out for that purpose. It's still a great medicine for other things. Women's health, other things. Women are being told they don't eat, especially after a certain age, and if they're monogamous, they don't need pap smears as often as they've had it.
Yeah.
They don't need mammograms as often as they've had mammograms after a certain age. They're also being told that if they have asymptomatic urinary tract infections, if they have some white blood cells and small amounts of bacteria in the urine, those should not be treated because we are getting an awful lot of resistant urinary tract infections, particularly in women, because they have been overtreated. Make sure that your doctor, if you do have a urinary tract infection, gets a culture and gets the sensitivity. And quinolones, and that's particularly Cipro and Levaquin, now have black labels saying that they may cause tendon rupture, which they can cause in people, and if you get a UTI, not pneumonia, Levaquin is probably the best thing for that. If you get a UTI, take sulfa, take amoxicillin, take a tetracycline, take Keflex, try to avoid taking what we've been getting mostly, which is Cipro. We are going to have a session on joint disease and osteoporosis. That I think is in February. Strongly recommend you attend that one. But big change in osteoporosis has been the recommendation that you don't start getting bone densities when you're 50, women, but you start getting them more likely when you get to be in your mid-60s. And then you get treated more aggressively. You should get 5 years, the recommended therapy right now is 5 years of bisphosphonates, which is Fosamax, or Actonel, and there's no point, if you're going to take it for 5 years, of getting a bone density in between. 2 new treatments which might be better and which are not yet available because they are expensive and have to be given by injection. One is something called zolendronate, which is an injection given twice a year, which is like Actonel, and something called Prolia, which is a biologic drug, which is given by a regular injection twice a year, which is really very effective. And there is some speculation that when Prolia becomes generic, it's probably going to take over as the drug of choice for treating osteoporosis in most people. Joint surgery has improved significantly. We have robotic joint surgery now, and we're going to have a session on that. Arthritis, another thing, biological medications. There are lots of them out there. They all end in AB. And whether they are used to treating osteoporosis or Crohn's disease or rheumatoid arthritis, Humira is an AB drug. All these things that you see advertised, they end in AB. They're all biologicals. They are wonderful drugs. They are expensive drugs. Again, they are going to be used much more extensively in the near future. Quick stuff on ear, nose, and throat. Very important. The drug of choice for allergic rhinitis, hay fever, or for colds, or for mild sinusitis, now considered by the American College of Physicians and the ENT people, is, would you believe, a nasal steroid spray. Flonase, fluticasone. A lot of people can't tolerate it, but the reality is they work better than antihistamines. They work just as well, and they don't give you side effects except the local ones, which can be annoying, but that's the choice. Sinusitis should not be treated with antibiotics until you have had it for at least 7 days. Everyone agrees to that. You know, most sinusitis is related to viral things and will go away. A study that just came out last week comparing different kinds of cough medications to see which stopped your cough better. Which one was just as good as any other one? Placebo. Most of your colds will go away in 7 to 14 days or 1 to 2 weeks, no matter what you do about them. There's lots of over-the-counter medications. There's lots of prescription medications for colds. Some of them have side effects. Some of them don't. Most of them cost money. Don't take them. Marijuana, quick word about marijuana. It's now available to treat seizure disorders. You have to get it in a special place. It's also legal in certain states.
New York.
Not New York yet.
Yeah, it is.
Not legal, no, medical marijuana is,
Yeah.
but over the counter. Drug dealer marijuana is available in Colorado among other places. It's your Rocky Mountain High. A lot of uses for marijuana are going to be out there in the near future, and now that they seem to be able to separate the stuff that makes you high from the stuff that helps you, don't be shocked if in a few years marijuana replaces codeine as your drug of choice for pain. There was a report that is unofficial, industry sponsored. You know what that means? That something called Vasepa, which is an omega-3 fish oil, is very effective in treating your cholesterol and treating your heart disease. That might happen. Sales of this drug went down when fish oil pills were not shown to help some things, but don't be shocked if you see something about that. A lot of people have abnormal liver function tests, 8 to 10% of people. That may be due to obesity, it might be due to your medication, it might be due to alcohol. The only thing to do about that is get a sonogram to make sure there's nothing weird going on, make sure there's no hepatitis going on, and just follow them. If they get worse, start taking away medications. Most shocking thing to me this year, if you have appendicitis and you get to your doctor early and get your CAT scan early, you can treat it with antibiotics. And over a 5-year period, this was done, I forget, in Denmark or Sweden, over a 5-year period of every 100 people who had appendicitis treated with antibiotics, only 40% of them needed appendectomies eventually. Everybody else did fine. Now, it's pretty scary to go to the emergency room and have somebody say to you, you got appendicitis, take the antibiotics and come back in a couple of weeks. You know, that's not what we were taught from day one, but that may happen one of these days. Sleep problems. A couple of studies this year showed that the best treatment for people who can't sleep, particularly elderly people, is
Turn off your smartphone.
Turn off your smartphone. Psychotherapy compared to the Z drugs, Zolpidem, and psychotherapy. You haven't got a problem. But psychotherapy really helps your sleep problems. Sleep apnea, you feel better if you get a CPAP machine and use it, but as opposed to what was thought before, it does not prevent heart attacks. There's something called procalcitonin, PCI, that is out there now. It's a new blood test that is not yet available except in some emergency rooms and hospitals, but it seems to be able to distinguish with a great number of percentage between viral bronchitis and bacterial bronchitis, viral pneumonias and bacterial pneumonias. And it's not available in your doctor's office, and it's something if you get through a lab, which is not available in general labs, no one's paying for it yet, but be on the lookout for procalcitonin in the future as a way that you might decide whether you really need that antibiotic for your cold or not. Dementia. Not much to say about that, really nothing new in terms of that. The important thing that's been proven again, if you get a cholinesterase inhibitor, Aricept, Namenda, any of those, make sure your doctor tells your person who's with you to start it low and slow, and not to give a large amount at once. Give the maximum amount at once, immediately. A lot of people get side effects. With anxiety, a paper just came out showing that benzodiazepines, Ativan, Valium, and so on, for 6 months might be safe to treat somebody with significant anxiety. After 6 months, it generally does not help, and it leads to increased something called all-cause mortality. It means you're dead, although it doesn't say why you died. Two other drugs that are used for dementia, particularly when people are very agitated, are risperidone, which is Seroquel, and haloperidol, which is Haldol. Both of them showed earlier deaths if you give them to people, particularly those people in palliative care, and they are being abandoned. Falls. I'm pretty much almost done. Those fall asleep. Falls. We are experienced as we get older a greater incidence of falls, and they've been looking for things that help falls and help prevent falls. Obviously, get your rugs tied down, put a little light on so that you get up in the middle of the night. You get up, one, sit first and then stand, and two, you have a light to follow. What's amazing thing has been shown to really prevent a lot of falls in the last year is something called Tai Chi. You see these little Chinese ladies walking around the neighborhood and you see them doing this kind of stuff. It really helps to prevent falls. If there's anybody here who wants to start a Tai Chi class in our social hall, let us know. That would be a great thing to do. Really. You do it?
It would definitely be great.
Yeah. So think about that. Somebody, I'd like a volunteer to think about doing that. CAT scanning for smokers. There's only a couple more things left. CAT scanning for smokers. It's been agreed now that people between the age of 55 and 75, 77, something like that, should have an annual low-dose CAT screen to look for early lung cancer, which you can treat, as opposed to waiting until it becomes real lung cancer, which you can't treat. And remember, anybody who's had 30 years of smoking history in that age group should have it. The microbiome and probiotics. We live with a few billion bacteria in our guts. That's called the microbiome. In 1905, a man named Mechnikov, who won the Nobel Prize, somewhere around there for something different, said, everything depends on the bugs in your gut. That's why people take probiotics, and nobody really knows whether they help or not. Some people feel better when they take them, but microbiomes are going to be studied, and we'll be hearing about them in the future. Vitamin D has been shown to not do as much as what vitamin D was supposed to be doing 2 years ago. Good idea to have a quote, normal vitamin D, end quote, which is around 30, but unless your number is less than 20, which doesn't happen too often, it probably isn't gonna do you any good to take it. It's cheap, it's easy, it won't hurt you if you take only 2,000 units a day, but it's not gonna prevent all the things that you think it will.
Doc,
Yes.
if you're on an estrogen blocker and you're told to take 2,000,
Against?
if you're on an estrogen blocker and you're told to take 2,000 mgd,
Yeah.
is that,
Of the vitamin D? Again, it's not gonna hurt you. Nobody knows what a really high vitamin D is gonna do for you or against you. But there's no harm in getting your number up to 50 or 60, for sure. But a lot of people have been taking too much vitamin D. Well, real quick. Vitamin B6, pyridoxine, they're a lot, it's red.
It's okay, it's working.
A lot of people,
It's working.
it's working, oh, all right, it's working, it's red.
You're better without the microphone. I don't know if they can hear over there.
Vitamin D, vitamin B6, don't take too much of it because it can cause a peripheral neuropathy. And I've seen people taking it too much. Peripheral neuropathy means you can't feel what's going on in your feet too well. Not a good idea. And a lot of elderly people are because they're getting older, are not absorbing the vitamin B12 they should. If you're anemic, tell your doctor not just to look for iron levels, but to look for B12 levels. Stuart?
Is replacing your exposure to sun, the benefit of getting sun?
Well, sun, I mean, people are avoiding the sun because of skin cancer at this point, and a lot of people, because of that, have low D levels. Muslim women have notoriously had low D
So
levels.
can you address that by going outside in a safe amount?
You can go outside, but you're not gonna find too many Muslim women going outside without.
I'll stop looking for them.
Something called Baloxavir. What's Baloxavir? It's a new drug, not available yet, but it is useful in treating influenza. It's not available, it'll probably be out in a year.
For influenza.
I quit. I have a couple of things I could say, but some questions? Yes, ma'am.
Yeah, I have a question and a statement. So my question is the ibuprofen with acetaminophen, if you're on an anticoagulant.
No, not the
So is
ibuprofen.
there something else instead of the ibuprofen?
Tylenol.
Just plain old
It's safer to take an
acetaminophen.
opioid at that point. Tramadol is safer than the stronger opioids.
Right, okay. And PSA, my father died of prostate cancer at the age of 88.
Okay?
So,
I mean, he was told after 70, don't worry, it's not gonna, the PSA is up, it doesn't make any difference, da-da-da. And he
When did it become
more
metastatic?
aggressively. I'm sorry?
When did it become metastatic?
Probably at, he was probably about 80, I guess, or more.
I'm not gonna go into that now because it's
No,
really
but
complicated.
It's
It's just that
his
some people
father
feel that
lived
way.
to 99, so I feel he got cheated out of the money.
So my father-in-law had prostate cancer and radiation when he was 63. He lived to 88 after that, and he did fine. But he probably would have done well without the radiation. Because
Yeah, my father didn't have radiation until way past.
Yes, sir.
Has the 4K test replaced the biopsy for prostate cancer?
Say that again?
The 4K test.
Not officially yet. And it's not, I have one patient who actually got septic after a biopsy, ended up getting 3 weeks of IV antibiotics in the hospital because of that, and it happens.
Just a second, I'll tell you. I just want to see something.
Yes, ma'am.
Between vaccines, how long should you wait?
Which vaccine?
like did the senior citizen
Like the-
flu shot? if you
Flu
wanna
shot
take-
once a year, doesn't
No,
matter.
I'm saying, but let's say you take the senior citizen flu shot.
Yeah.
Right? The seniors. How long should you wait to take the shingles vaccine?
Oh, the next day.
Yeah, you don't have to wait like 2 weeks?
Or you should wait a week, because you may get side
And the
effects.
same thing for taking the pneumonia shot after the flu vaccine?
Yeah, a week later is fine.
You know what, maybe I should just take the pictures so we do it a little more orderly. Maybe I should take the questions and we do it more orderly.
A week later.
Well, I mean,
That's what we're doing.
if anybody wants to write some questions down, we can do it that way. But I'll answer some verbally, sir.
Your admonition,
Is that a Mets shirt you have on? You know a lot, I mean, I'm a Mets fan, but
your admonition against eating ice cream in monumental, does that count for